everyone. Today we will be talking about how a miscarriage happens. We'll talk about the medical stuff, but also about the psychological consequences of having a miscarriage. A miscarriage, also called a spontaneous abortion, is the loss of a pregnancy during the first 20 to 23 weeks, and a loss after that is called a stillbirth. The main sign of a miscarriage is vaginal bleeding or spotting, cramping, and pain in your abdomen or sometimes lower back, and fluid or tissue passing from your vagina. It's important to note that vaginal bleeding is common during the first trimester of pregnancy, but it does not necessarily indicate a miscarriage. And the causes of miscarriages are not usually identified. The majority are not caused by anything that the patient does, and so the majority cannot be prevented, unfortunately. And most are caused by abnormal chromosomes in the baby. Among people who know they're pregnant, it's estimated that about 1 in 8 pregnancies will end in a miscarriage. Many miscarriages happen before the person is even aware that they are pregnant. And losing 3 or more pregnancies in a row, called recurrent miscarriages, affect 1 in 100 women. The risk of miscarriage is multivariate, meaning that there are a variety of variables that can influence the happening of a miscarriage. And there is not one single predictor of future pregnancy loss. But some of the risks include maternal age and obstetrical history. So these two are the most important ones that we've found so far in research. So in women aged 20 to 30, the risk of miscarriage before 20 weeks of gestation is around 9%. And in women above 38, this increases a lot to 75%. The risk of miscarriage in a future pregnancy is approximately 20% after 1 miscarriage, 28% after 2, and 43% after 3 consecutive miscarriages, 3 or more. There are a variety of other risk factors that can influence the happening of miscarriage. Here are just a few of those, like thrombophilia, antiphospholipid antibody syndrome, extreme maternal weight, and hypertension. The male factor is also very predictive of a miscarriage, since the quality of the sperm dictates chromosomal abnormalities as well. Some signs of early pregnancy loss include pelvic and abdominal cramping, possible vaginal bleeding, like we were saying in the beginning, a positive pregnancy test, and missed or abnormal menstrual cycles, meaning that you already know that these symptoms aren't normal to be feeling because you already had a positive test. Upon these symptoms, we must ask ourselves, is this a true loss? Is this an ectopic pregnancy? Is this a molar pregnancy? Or is this a viable pregnancy that just has some complications to it? So the true loss happens when, the pregnancy isn't viable, or the baby has already died, or, the development of the pregnancy is already inevitably lost. An ectopic pregnancy, for those who don't know, happens when a fertilized egg implants itself outside of the womb, usually in one of the fallopian tubes, and it won't develop into a baby, and the health of the patient may be at risk if the pregnancy continues. A molar pregnancy happens when there's a problem with the fertilized egg and the baby and the placenta do not develop the way they should, and so the pregnancy is not viable as well. And then we can have a pregnancy that is viable but needs a little bit more care in order to make it go full term, because it has some complications, but it will develop. When we want to answer these questions, when we want to make sure what we are looking at, it's important to do a transvaginal ultrasound and also an ACG test. Some treatment options include expectant management, medication, and surgical intervention. So let's look at these one by one. So In expectant management, we are waiting until the miscarriage is complete and until the body does its work. This is possible only for those who are miscarrying in the first trimester, and around 80% of women achieve complete passage of intrauterine contents within 8 weeks. Then medical management. Misoprostol is the most common medication used for this, and it can be used in the absence of other contraindications to achieve induced passage of intrauterine contents. These contraindications include severe anemia, bleeding disorders, or infection, and most women will achieve complete expulsion of all the contents within 3 days after taking 1 or 2 doses. And then the surgical options. This is achieved with sharp or suction curettage. This is preferred in women who present with hemorrhage, hemodynamic instability, signs of infection, or have comorbid conditions like cardiovascular disease, infection, severe anemia, or bleeding disorders. Again, if, for example, you are not on your first trimester and you're having a still birth, you might be induced into birth, so you can pass all the contents. Now we're going to talk about the psychological components. We're going to start with this article right here called Quality of Life and Psychological Distress in Women with Recurrent Miscarriages, a comparative study. So this study says that women with recurrent miscarriages show a significantly higher degree of psychological distress than those who do not have recurrent miscarriages, but, for example, compared with those who do have miscarriages but just not recurrent. They also show lower levels of quality of life, and quality of life is a construct that has different dimensions. This was lower significantly in role physical, general health, vitality, social functioning, and role emotional and mental health. And it was lower, but not significantly lower, in physical functioning and bodily pain in these women. Even if it's not significantly lower, it can be just a sample issue, or if that is true for the entire population, it is still lower. And it's something to look at, of course. They also show extensive functional disability and lower levels of well-being. So I thought it would be fun for us to just do a quick analysis of some numbers here that compare the quality of life between women with and without a miscarriage. So here are women who never had recurrent miscarriages and those who have recurrent miscarriages. And remember, a recurrent miscarriage is defined, with sometimes 2, but 3 or more in a row. It's considered a recurrent miscarriage event. So here regarding physical functioning, so one of the subscales of quality of life, or a domain of quality of life, you can see that it is higher in women without recurrent miscarriages. And this isn't significant, but it's still higher, and you can see here the difference in the mean scores. Then role physical, it is significantly higher in women without miscarriages, meaning that, once more, those who do have recurrent miscarriage have it worse. Then bodily pain, of course, it is lower for those who don't have recurrent miscarriages. General health is higher for those without recurrent miscarriages, significantly. Vitality is higher, also significantly. Social functioning, role emotional, and mental health are all higher in women without recurrent miscarriages in a significant statistical way. And then I also thought it would be fun to see the comparison of anxiety, depression, and quality of life among women with a history of recurrent miscarriage that have or do not have a child. So these are women who all went through an episode of recurrent miscarriages, but some of them ended up with a child, and some of them didn't, or already had a child before they went through this event. Okay, so anxiety is higher for those who went through an event of recurrent miscarriages and do not have a child, and this is a significant increase. It's also high for those with depression, significantly. It's also high in terms of depression for those who don't have a child significantly. Physical functioning is lower, although it's not significant, it is lower. The role physical, it's higher, even if it's not in a statistically significant way. Bodily pain is also higher. General health is lower in a significant way. Vitality is higher. Social functioning is lower. Role emotional is lower, and mental health is lower, also in a significant way. So we can see that it is not just having recurrent miscarriages or not. There are other factors in life that also impact the way that this event will shape us and will, give us ramifications. In this case, having a child sort of works like a protective factor and helps some of these bad things like depression and anxiety not be as bad. And I do think it's important to say this because, for example, anxiety, depression, general health, and mental health were all significantly shown to be impaired in those without a child that do go through recurrent miscarriages. And now we're going to talk about the psychological impact of early miscarriage and client satisfaction with treatment. And we're going to compare two treatment options, expectant management and the medical treatment with misoprostol. So the psychological response to and recovery after early miscarriage did not differ between women treated with misoprostol and those who were treated with managed expectantly. And symptoms of grief, anxiety, and depression after one early miscarriage are in most cases short-lived. The duration and amplitude of these symptoms are similar in women treated with vaginal misoprostol and those with managed expectantly. So this is quite interesting. We can see that the treatments did not provoke different reactions in women, that if the miscarriage happens early on in pregnancy and it's only one, it can be short-lived in terms of the, anxiety, depression, general health, mental health that we were talking about before that were impaired. And so it's important to see that these symptoms are similar. It doesn't matter which treatment course women go for. Satisfaction with treatment was high in both treatment groups, so women didn't seem to prefer one over the other. Patient involvement when deciding on the management of early miscarriage was shown to be very important for women and very empowering. And women can be reassured that these two courses of treatment have not been shown to provoke any adverse psychological responses and are, medically speaking, safe to do. So this was our presentation for today. If you have any questions or you would like to talk further about the subject, you can reach me through Instagram at Beatrice_Regina_fertility, or you can write me an email, beatrice@efp.clinic. I hope you can leave me some comments and I'll answer to those. Thank you so much and hope to see you next time.